Hi, hello everyone. So thank you so much for such a lovely introduction. As was mentioned, I'm Eleonora Harwich, Director of Research at a think tank called Reform. I am actually very, very interested in this topic of the ethics of data sharing in healthcare. I'm actually very happy to have a stellar panel with me today. So to my right, there is Heather Flannery, Global Lead at ConsenSys Health. Then right next to me, Samantha Nazareth, Chief Medical Officer at metaMe, Inc. And then to my left, Navin Ramachandran, who's a healthcare specialist in distributed ledger technologies and IoT, and is at the IOTA Foundation, amongst many other things, I'm pretty sure. So what I thought is that I would give the opportunity to the panelists to introduce themselves very briefly, because I think they would do that better than myself. And then we would kick off with some sort of general questions and a hopefully very engaging chaired discussion for sort of next half hour or so. And I thought that then I would open it up to the floor for the last, say, 15 minutes. So please do your homework, pay attention, think of some questions, because if you don't, I will pick on you. So Heather, would you like to start maybe?
Certainly. Thank you so much. Good morning, everyone. It's an honor to be here. I'm Heather Lee Flannery. I'm Global Lead at ConsenSys Health. For those of you not familiar with ConsenSys, we're the largest pure-play blockchain company in the world, founded by one of Ethereum's co-founders, Mr. Joseph Lubin. We have about 1,000 people across 20 countries working on enterprise solutions for that are built on top of the Ethereum protocol, and it's my accountability to lead value creation with those assets in healthcare and life sciences. I'm extremely mission-driven and passionate about this particular field, and I'm kind of a glutton for punishment around volunteer leadership opportunities. I chair a standards development working group at IEEE at the intersection of blockchain and the healthcare and life sciences. I am the co-chair of the Global Blockchain Task Force at the Health Information Management Systems Society, or HIMSS, and chair the Healthcare Special Interest Group at the Enterprise Ethereum Alliance. Thanks for being here.
Wow, that's a lot of responsibilities. Very impressive. Sam?
I know, it makes me feel like I'm not doing enough. I'm delighted to be here. I'm Dr. Samantha Nazareth. I am a practicing gastroenterologist in New York City. And along with that role, I am Chief Medical Officer of a company called metaMe. And metaMe is a data platform. I describe it in sort of 3 layers. First layer is a way to store your data, a way to monetize or assign value to that data, and then finally, it's an opportunity then, since your data has value, to exchange that data.
Really interesting. Navin, last but not least.
Hello, my name's Navin. I usually get trotted out to be the naysayer. So my background is as a doctor. And I'm still full-time doctor, and I'll be going back there after this. Recently, I joined the board of directors of the IOTA Foundation, and my job previously was to look at the use of distributed ledgers in healthcare, but now I've got a wider role overseeing engineering as well.
Very cool. So I thought we'd start by a kind of very broad question addressing hands on the topic of this panel. So for you, what is the biggest challenge that healthcare systems face when sharing medical data for kind of secondary, or what is known as secondary purposes? So I thought maybe we would start with either Samantha or Heather to have a bit more of the kind of maybe US perspective, which could be quite interesting, and then I'll go to Navin to have a bit of a more UK take on this question. Samantha, do you want to?
Sure. So I see it on both sides. From the physician side, seeing what hospitals are doing. This happened recently in New York City, where I'll just kind of paint the picture of someone coming in for cancer treatment, let's say. And they're undergoing chemo, and they have pathology extracted from, let's say, their tumor. And then years down the line, that data is being sold by the hospital to a third party that they've heavily invested in. And as the patient, you would have not have known that maybe in the future my pathology was going to be sold. Secondly is this whole rise of citizen scientists, all of these direct-to-consumer companies, and with that, it's almost a double pay because the consumer has to pay to actually share their data because they're kind of gaining some knowledge from using these DTC. And then with that, later on, then the data is being sold to a third party. And in both instances, the patient and the consumer may have not have known that this transaction would have happened years down the line and also weren't part of the transaction at all.
I agree with your observations, Dr. Nazareth, and adding to that a little bit regarding the U.S. perspective, we actually have some really exciting regulatory forcing functions that are coming into play in the very short term that I believe, or I hypothesize, is going to really make a massive difference with respect to the portability of health information, which has been completely unattainable thus far in the U.S. market. But first, I think it's important to clarify the policy environment and the ethical implications as separate for institutional data exchange, or you could think of it as business-to-business data exchange, and patient-mediated data exchange, which may or may not involve the patient first having custody of a piece of data. So there's a couple of different layers there and policy and regulatory constructs that apply to each of those. First, I would mention what's referred to as TEFCA, because we love phonetically pronounceable acronyms, and that's the Trusted Exchange Framework and Common Agreement in the U.S. market, which sets up an entirely refreshingly new paradigm for institutional data exchange. That could be thought of as in two categories, identified and de-identified data, again with regulatory and policy parameters applying to both. And then with respect to patient-mediated data exchange, we are in the final stages of a law in the U.S. Called the 21st Century Cures Act. And it was passed several years ago, and the most challenging piece of the law naturally has taken the longest to implement, and that's around a term called information blocking or data blocking. And it creates for the first time, a defined legal term for a new illegal action that will be subject to investigation and enforcement provisions, much like privacy laws under the U.S. HIPAA Act. And it requires that HIPAA-covered entities are obligated to place their health information data behind a RESTful API and make it semantically available in the FHIR format, which is Fast Healthcare Interoperability Resources. So it sets a mandate for a data access architecture, and it sets a semantic structure requirement that all HIPAA-covered entities will be required to support. And the key is that there is also another term, no undue inconvenience, meaning that a patient from any mobile application should, with no more than 2 clicks, which is specified, no more than 2 clicks, be able to request some subset of their health information and have it received to a patient self-sovereign data store. So that maybe lays a little bit of the foundation of what's about to change in the U.S. market, and it certainly opens the door to a great deal of chaos and risk, as well as value creation. And the intersection of blockchain with all of those, I believe, greatly reduces the chaos effect.
Thank you. That's very interesting. Navin.
Cool. So we look at it slightly different in the UK. And there are big differences between the UK and the US and how healthcare works. So if you look at how healthcare is delivered, it tends to be, within the UK, there is a general agreement that healthcare data should be shared between institutions because people tend to have their care, say from their GP to one hospital, may have surgery one hospital, radiotherapy another hospital, chemotherapy another hospital. There's a general agreement that they should all share, whereas in the US, there tend to be more monopolistic approaches where you have healthcare verticals where your GP, your primary healthcare worker in the hospital and your secondary all tend to work, say, within somewhere like Kaiser Permanente or other big institutions like that. They share their records, But if you ever want to move to another hospital, it's incredibly hard. So I think there is a difference in approach for that, and that's in terms of sharing healthcare data for ongoing care. There's a separate issue around value extraction. So would you share data so people can analyze it, build AI models out of it? And again, I think there's a slightly different approach there because, again, these same institutions tend to know the value of their data. And so if they enter into partnerships with companies, they tend to get money out of it, whereas in the UK, we're pretty bad at it. And although the NHS is seen as one big institution, actually most hospital trusts tend to work separate to each other, and there's no coordinated strategy around it. So what that tends to mean from the UK side is that the NHS and the public tends to lose out. So those are two things that we're looking at in a big way. And when we get on to how that data is shared, so you touched on it, semantic interoperability, that's a big word. What that means is, if I share data with you, will you actually understand it? So the way most people share data now is to hand over a set of photocopied notes or a big PDF. So you get a big PDF document, which could be hundreds of pages long. To actually find the information you need within it is incredibly hard. So there's a semantic interoperability means all the data is kind of coded, and when I send it from my system to yours, it automatically imports it. So it knows you've got diabetes. It knows that you have an allergy to something. That's incredibly hard, and it's good that you're taking up the FHIR standard in America, but my work before distributed ledgers was on semantic interoperability and looking at open EHR and FHIR. And the main problem with FHIR is that FHIR stipulates that if it's present in 80% of healthcare systems, then we'll incorporate it as a FHIR standard. But actually, if you look at all of medical data, that probably amounts to about less than 1% of the type of data you'd look at will be coded in FHIR. So all the rest, you have to make specialized types, and every hospital will make its own specialized type, and suddenly they won't be interoperable anymore. So we've tried this before, and though it's a great idea to try it, I think it will fail, ultimately.
I feel like I've been challenged.
Yeah.
May I have an opportunity to react to that?
Please, of course.
So, so I think as a person who's involved in standards development, I think that we often overestimate what is possible through the development of any particular standard, especially at a data semantics level. And while FHIR is not a perfect standard, it is important that we have a framework level structure. But I agree that even in standards nirvana, we would, even if it were our absolute idealized perfect state, we would have an enormous amount of data that would remain unstructured. All imaging data, all notes from every clinical provider, every kind of, there's an enormous amount of unstructured data that cannot be addressed or realized with any semantic data structure. So this gets into where we can use the convergence of this and other technologies to transform and bridge between structured and unstructured data and semantics. So that's not the topic of this panel, but I'm simply asserting we do still need framework level standards, or we won't be able to use AI or natural language processing for the totality without any structure.
Yeah, no, I'm not disagreeing with. But yeah, if I
Go
come back
for
to
it, please.
So I think the change will come, and this is where I think distributed ledgers come in. I don't think distributed ledgers will have an impact on current healthcare because there's too many vested interests to make that change. Because the point of it is to try and break a monopoly, and most people don't want to break that monopoly. But I think where that change will come is when new entrants come to the market, and we're seeing it in like the big data providers are coming in. And actually what that means is a fresh start, in that you will start getting new data generated, which can be semantically accurate. So especially if it's machine generated or sensor data, then you'll see it semantically accurate. And you will see it originating outside the firewall of the different hospitals. And when you have that, you have an opportunity for change. The reason I'm interested in distributed ledgers there is, how do you ensure that data, once it's generated, isn't altered on the way in. And for me, that's the change. When you start making data outside monopolies and comes from everywhere, how do you then know that it's accurate and it hasn't been tampered with?
Great. So I was thinking, actually, picking up on some of the topics that some of you touched on earlier, was that idea of, I guess, sort of fair apportioning of value and how you actually should go about extracting value from data. So be it, sort of companies making money directly and patients just not getting anything, or should it go back to kind of the healthcare system? And I guess I'd like to get your views on how you feel about patients being directly remunerated for sharing their data. So say, let's take the kind of thought experiment of it being third parties that would be part of the kind of private sector. So say a big company trying to develop an algorithm, or a pharma company trying to develop a drug.
Oh, I'm definitely for it. I think at this point, in the U.S., it's really digressed sort of from the inclusion of the patient, not just the patient, actually, the doctor. I saw Toby's slide of the 1 trillion. It's not being distributed to basically the end users, the people that are kind of the most important, the physician and the patient at the end of the day. And at least in my practice, I definitely would want to incentivize my patient to actually do what I tell them to do in a little, if it's in a monetary way or if it's just access to something else. But day to day, as you can imagine, GI, I see bloating, reflux, constipation, and bleeding hemorrhoids. Most of those things can be treated by lifestyle interventions, but I know once the visit is over, what are they doing at home, and how are they participating in that decision-making of kind of taking the advice of the lifestyle things that I recommended. And so I think this is an important point to say, that this is a way to include the patient in either monetizing them and participating in their care finally.
Yeah, please, Heather.
So I also concur, express general support for the notion that opportunities for either remuneration or donation of health information are generally ethically appropriate. However, that doesn't mean that we don't need to take a very careful look at policy decisions, and that there are not many opportunities for unintended consequences with models like that. For example, the way that an incentive motivates different populations can be radically different. If you're talking about a population that is socioeconomically disempowered or vulnerable, providing economic incentives may feel less optional or be less optional. So I think as we think about incentives, we must also remember they may not always need to be monetary in structure or form, and that if the goal is to motivate protocol adherence, there may be a variety of methods to accomplish that involve not only cash or monetary compensation, but other kinds of gamification and ways of activating or engaging. The field of digital therapeutics is doing terrific work in discovering what those things are and how they apply to different cohorts. But generally, if we view data as needing to become property and be treated as property under the law, and if we clarify what parties own data under what circumstances and under what jurisdictional boundaries, I think we can apply the lens of both property law and labor law and different contract constructs to try to develop a model that would actually be a much stronger bioethical posture than what we have today.
I think that's quite interesting, because I think the UK healthcare system being just so totally different, that I think for most people that would be equated to genuinely pricing your own privacy, because that's ultimately what it is. You're putting a price point potentially on your own privacy. And I think it's quite interesting that kind of point that you brought up about the adverse effect that it might have on certain subpopulations for whom that might not be a big choice to decide to actually sell your data or not, because that extra £20 a week or whatever it is could make a hell of a difference to their own budget.
I've seen,
yes.
there's been talk about it at even government level about how you have disadvantaged areas of the UK or the elderly population donating their data and getting rewarded for it. And that seems slightly ethically unsound to me, in that you are now the data donors. Equivalent to what happened with, say, the pharmaceutical industry in the 80s and 90s, where the big trials happened in third world countries because life was cheaper there. And then the knowledge from that went to sustain the well-off people. I think that there's also a bigger issue around monetization of data, and that most people don't value a single person's data. And so me personally saying, here, have my data, that's not worth that much. It actually becomes much more valuable when there's a group together. And so I think if you're going to monetize, I'd see much more likely that certain patient groups may come together. So with a certain illness, they'll come around and say, you can have access to our data and do work with it, but you reward this association rather than individuals.
So you think potentially in a kind of like socialized healthcare system like the UK is a bit, maybe a kind of data trust model would be?
Yeah, I mean, that's what they're trialing here, is that they're trialing data trusts amongst, I don't know, there's a certain cohort number, so is it like 200,000 or 2 million? But amongst that, these people get together and say, we will behave a certain way and we'll pool our data together and use it for what we think is appropriate. But that's been trialed out there.
Are there any sort of equivalent trials like that in the United States that you might be aware of? Because it's almost like the kind of modern day and age trade union model, but for data. Do you think that that's something that could potentially be explored?
I suspect that many patient advocacy groups will be evolving in that direction and will begin to hold data assets in custody on behalf of the population that they're representing, and that a new function of their business model will be achieving, population health, clinical, and economic outcomes based on the data that they're holding. There are data commons activities in the U.S., and there are a range of different legal experimental structures for how to do this, from co-ops to trusts to you name it. So there's a lot of experimentation going on, but I don't think anything is really baked in yet as this will be the go-forward construct.
So I was sort of wondering if we could move the topic a teensy bit to the actual possibility / kind of practical side of putting dynamic consent in place through, either kind of distributed ledger technology or whatever other technology, and the granularity and level of consent at which we can get, and is that actually practical, that people might be receiving constantly notifications to say, well, can you share this bit of data with X or this bit of data with Y? And I guess what are the most potentially viable examples that you've seen? Sam, I don't know if you've sort of been involved in this space, but yeah.
I was just thinking in a practical perspective of how this would work in New York City.
Yeah.
And I have to say that, so I do procedures, I do colonoscopy, endoscopies, and people get put under anesthesia. And I have patients that would come in and do this procedure and then immediately go to work after. So you can imagine they're on a time crunch of a get in and get out, and the dynamic consent in that aspect and in that mind really would not work. In theory, it's very beneficial, but I think three things need to happen. One, the education of the patient. Two, education of the doctor in terms of that kind of consent. I mean, we do have to give consent for everything we do, and it's called informed consent, so the benefits, the risks, and alternatives to doing, let's say, a colonoscopy have to be given, but in the context of kind of this rushed care, if you will, that is happening, especially in Manhattan, it's really, really tough.
So I think I'd first clarify or distinguish between informed consent and standard of care protocols, research consent, both at a population health or a clinical level, and data use consent. And they have three very distinct sets of implications, and we're coming from different places in all three of those paradigms. I think that with respect to data use, the third of those scenarios, we will definitely, using this technology and converging innovations, move to a model where instead of blanket consents involving always blanket consents depending on whether it's de-identified or identified, we will be moving to explicit transaction-specific consents. Completely distinct, though, from informed consents or research consents, research participation consents. The one point, and I think we're going to get to this a little bit later in the panel, though, is a lot of this notion of consent presumes when we talk about it and we think about it, we're imagining a consent for data use being granted and then some data moving from point A to point B. That's what we're imagining.
Yeah.
I think that our future state looks differently than that. And as we are seeing the convergence of blockchain with things like federated learning and also access to more and more real-time data streams from external to the healthcare environment, we're more likely talking about accessing some data versus necessarily moving it. And this intersection of federated learning and blockchain in the context of data use is very interesting and a burgeoning field right at this moment. A year ago was nowhere on the landscape. 1 year later, there are multiple large-scale initiatives working very hard on the technical underpinnings to enable that. My organization is one of them. But.
So when I look at consent, I do split it differently. So there is, I think informed consent is valid for all of the types you're describing, in that you should know what you're agreeing to. But in this context, we're talking about...
We agree on that.
Yes.
For sure.
But we're talking about informed consent in this way as for a procedure or something that's going to happen to you. And that's a point procedure. Where you have it and you may have side effects later on, but it's happened as a direct result of something you're about to undertake, and that's a medical kind of consent that we take. There's a separate kind of consent, which is the data sharing consent, or use of data consent, that you tend to take when you're undergoing a research trial, or if you're going to share some data with someone, or say if someone takes a photo of me. There's bits around there which are around intellectual property, who owns that, and also, and that's very separate to consent for people to use that data for something else. And that's where the granularity I'm interested in is, because when you say, I give the rights to use the data, what for exactly? So right now, what's possible with that data is like, I can print it. So 5 years ago, I allowed you to do it. Well, I could print it, I could put it on a PowerPoint presentation, no one would really see it. Move forward 5 years and suddenly it can go viral and it can be on the internet. So a silly photo of you which didn't matter that much could actually make you a laughing stock in the world. So these kind of things suddenly change the dynamics of sharing that data, and no one can predict in 10 years what that's going to be. So the granularity and dynamism of consent, I think, becomes much more important, because you have to be granular in saying what it's going to be used for, and it has to be dynamic in that even though I gave you consent now, in 2 years I may say, nah, withdraw. And that's what GDPR is pushing towards, in that even though I gave you consent to use it, at any point in the future I can revoke it and say, no, thank you, and you should be able to stop that going forward. So I think that will become much more important. And I think, that's one of the roles we're looking at on the distributed ledger, having a way of recording what your consent level is and your consent state.
And so what are the types of challenges that you're seeing trying to kind of, because I can definitely see how appealing it is in theory, but I guess it's one of those things where potentially there might be a bit of a tension between, I guess, what you ideally want and what is actually practically possible.
Yeah.
And so what are the challenges that you're seeing in terms of the implementation of those type of things?
The biggest thing is user experience. Like you alluded to that earlier. Exactly like GDPR, great idea, but if every time you go on a website it says, read all this and click agree, everyone just clicks agree.
Yeah.
So a great idea can become a bad implementation. So there's a lot of work, and we're undertaking some work at a couple of universities around that to see how can it be done. Are there basic defaults that can be used, and that will vary from country to country.
Yeah.
user group to user group. And so it's, can you align yourself to something that sets a basic set of defaults, but also allows you to change in the future, should you need to?
I was quite curious about that question that generally sort of comes up whenever we talk about the use of data, which is that question of kind of ownership and intellectual property rights and all of that over data. So I know that at least legally in the UK, that is a concept that does not appear in data protection law. There is no notion of property whatsoever. Data is more of a transactional relationship where obviously people have some duties and obligations depending on who they are within that transactional relationship, or a data subject or a data controller or a processor. But I guess I was wondering, why do you think it's a topic that continuously comes up, and why would it be an important one, or why would you need legislative changes around kind of ownership of data? Why is that necessary more than potentially the legal constructs that we have now? Heather or Sam, would you like to?
If we would travel back, say, 25 years into the past and speak with maybe a stock analyst or an economist about where the largest scale value for market capitalization in private companies would have emerged, it would have been an impossible concept, impossible to comprehend that the value of data could generate the largest market cap companies in the world. The 5 largest market cap companies in the world arguably are so because they've determined ways to take this thing that is not treated as property under the law and monetize it. We've had a complete restructure of our global economy as a result of this change. And now where oil as a commodity asset was the highest value total global domestic product asset, it's now data. We're living in a world where the inherent human data of an individual perhaps living in an impoverished economy, the value of that data in wealthy economies could outstrip their entire earnings potential in a year in that, and we're already there right now. So the need to restructure our regulatory and policy and ethical environments around this new reality, I think is paramount. It is not trivial, though, to determine what legal template ought to be applied. And there are sophisticated arguments going on around whether and what category of property law is most appropriate, where and how is labor law utilized, what about copyright law, what about any of those things. And then a detail that is incredibly fundamental to all of this is under American law and many other countries' laws, when protected health information or private health data is de-identified, it moves out of that category of legal protections. So essentially, the reason that American health institutions can monetize anonymized data is because that anonymized data, first of all, is presumed to be continuously anonymous, and secondly, is no longer viewed as connected to an individual patient. That this is an emperor has no clothes kind of moment. We all know now that de-identified data is re-identifiable. We've all seen what happened with Cambridge Analytics. We see the writing on the wall, and it's up to those of us in this room and in these kinds of venues to say, the emperor has no clothes. The notion of de-identified data is now a false premise. It's from a past historical paradigm. So de-identified data is also health information. De-identified data as a separate legal construct needs to be dissolved, and there are also great benefits for our industry and our institutions in doing so. Identified data where the identity is obfuscated, but the original data subject could elect to identify themselves and be activated into a trial, or participate in some construct that otherwise would be available to them. There are massive opportunities for value creation there that can be undertaken in an ethical way.
From the UK perspective,
Yes,
which is slightly different. So I looked at this about 8-9 years ago, and there's a Joint Information Services Committee, or JISC, which did some work around this. And I don't know if it's the same in America, but we view it slightly different in that the intellectual property and consent are separated, as I said before. The consent should always be taken for use from the patient or the subject, but the intellectual property rests with the person or who took the image. So actually in the UK, if I take a CT scan or an ECG of someone, what the hospital does, the intellectual property rests with the hospital, and it doesn't belong to the patient. And everyone goes, wow, that's odd. Actually, it isn't, because if you pay for a wedding photographer, they actually hold, even though it's your wedding, they hold the intellectual property of all the photos they take. And you enter into one of two types of agreements with them. And I went through this when I got married, is that either you pay them up front for those intellectual property rights and you can freely distribute, or some people you pay less and you have the right to use those pictures in limited ways. So I think this applies widely and not just in medicine. So I think that's how we have to view it, and that, yes, once it's taken, it belongs to the person who took it, but actually the consent is still needed. What's changed recently, though, is what is the person or entity that takes the recording? And that's the big change, in that now we have companies like Fitbit, just bought by Google, and other things, which are a machine-making company who then take up that copyright and the IP. So they say, when you collect that data about yourself, it goes into our data set or our servers, and it's ours. And you can request a nice, pretty graph visualization of it, but should you ever want all the raw data, you're not going to get it back. And in fact, what we're doing is building up these big banks of data about you, just as Fitbit did. And when their valuation gets high enough, they sell it off to one of the big 5 companies. And that's kind of what's happening in the world, is that all these small startups that you want to support are essentially building up big data stores and looking at an exit strategy to sell to one of the big companies. And that's what I'm worried about most.
God, that's a happy thought.
Yeah.
Great. So now I'm going to get rid of my Fitbits. So for the last 5 minutes, I thought I would open it up to the floor. So please, I would like to see some hands flying. If not, I will pick on people that I know. Oh, wow. Amazing. How should... Yes. So maybe question down there. And yeah, well, maybe I'll take them.
Oh, I think no.
I wanted to say to Ellie especially, I've read your document on the data-driven healthcare technology development. I just want to say how amazing it was. Thank you for developing it. I'm a lawyer and I work on medical data set licensing in particular.
Wow.
And I had something that I really wanted to clarify, especially around the consent discussion. So in my work, I come across a perception in the healthcare industry in particular that consent is a very good way of giving your patients control over their data, and there's good reason for thinking that. So there are a few different types of consent that are relevant in this context, as you've already mentioned. There's informed consent. So, for example, I'm conducting a clinical trial. I know that I'm a sponsor of that trial. I need the informed consent of my participants. That's one type of regulatory consent. There's a clear ethical reason for that. Another type of consent is under the, at least in the UK, the medical law of confidentiality. So if I'm collecting data in the direct patient care context, I then want to take that data out of that context and use it for a secondary purpose. So for example, I am developing a healthcare technology, I'm doing research, I need consent for that too. That is one type of consent. It's actually quite a low standard of consent. And then the final type of consent, as we've already talked about, is GDPR consent. But that is different because under the GDPR, there are a few different legal bases for processing that you can use. And it's true that consent is one of them, but consent in the healthcare context under the GDPR is particularly problematic because one of the requirements for your consent is that your consent is freely given. But if you've got a data subject who's in a poor condition of health, maybe they're in a position of institutional dependency on the care you're providing, maybe they're from an economically or socially disadvantaged background, and this is a point that Heather was making as well. Can you say that that data subject's consent is freely given? So in the UK, we're seeing this move away from GDPR consent in the healthcare context. And I just thought that was a really important point to make because it can seem from these discussions sometimes that GDPR consent is a good way forward in the healthcare context. But for me, it's problematic. It comes with a lot of baggage. And there's actually quite strict legal and regulatory hurdles in relying on alternative grounds like scientific research purposes. And maybe that's a better way forward. So I wanted to check if the panel had any comments on that in particular.
And the US, I mean, there's this whole capacity to give consent. Like, is this person with it? Are they alert-oriented ×3, meaning time, person, and place? And that that would speak to that aspect that you were mentioning. In every context of consent, the person has to have capacity. If they don't have someone next of kin or anybody else to speak for them, then a psychiatrist kind of has to rule that the person has no capacity, and then the doctors basically decide.
And just a quick remark on that is one of the things that I think has to emerge in these new infrastructures is not just the ability for granular transaction-specific consents to happen, but also for custodial relationships to be established, and delegation of authority is critical. And there's mainstream examples, children, and then all the circumstantial or perpetual lack of capacity situations for patients. But we have to be able to delegate custody. The question is, will we be allowed to delegate custody to an AI bot that we theoretically control? Will we be, which parties can be, what is delegatable, what isn't?
I agree with everything you say. There's one thing which you touched on, which I think we were discussing before as well, which is like murky ground, the reason to process, and this is the overlap of research versus service improvement. So lots of app development or model development is happening under the guise of service improvement, saying we'll take this patient's data and improve the service so we have a right to use it, but actually what they're doing is research and making money. And I think I'm seeing it in lots of places, and I'm a bit worried about that. And I don't know whether that will ever get to the courts. I'm hoping at some point it will, because I'm a bit worried by it.
Yeah. I think in terms of what I've heard in the sense of like trying to clarify the fact that the duty of confidentiality doesn't really overlap with what's in the GDPR right now, is that there's potentially going to be some work put out or some guidance put out by the ICO or maybe the National Data Guardians trying to clarify actually exactly that. What is a legal basis that you could potentially use under the GDPR that would work as well in health? But that's, work in progress. I think there were still two questions. So I think Toby had one, Helen had one, and there was one here. So maybe I'll take, okay.
You can leave me out.
I can leave you out? Okay, fair enough. So I'll take these two questions. So Toby here, and there was the lady right there. Yeah, okay, no problem. And then I'll have to bring the session to close. Oh, no, sorry, it was just in front here. Sorry, she had her hand up for quite a while. Sorry, yeah.
Hi. Do you think that the value of the data per individual patient, depending on the rarity of the condition, will take place? So we keep on talking about it as one patient, almost like use the term rate card. It's all the same, but somebody that might have a rare cancer might be much more valuable than somebody who has the flu.
It's happening already. So
oh, really?
One of the biggest rip-offs was 23andMe, which was kind of like everyone hand over your DNA and we'll tell you how much of a barbarian you are, or some nonsense like that. Nothing really medically useful, and they'll give you like some weird statistics, like you have 4% risk of gallstones. What that means to anyone, I don't know. But a whole bunch of people handed it over, and earlier, was it this year or last year? 23andMe said, okay, these people with known set of diseases, we're going to sell their DNA to a big drugs company for $6 billion or something. So yeah, there will be sub-cohorts whose data is more valuable, and I think there will be some kind of market to it. But bog standard people, I think it's harder to monetize the data.
So you're referencing in economics what we would call a price discovery function. And because all of the transactions that are going on are generally what we would call off-market today. They are point-to-point transactions without any visibility or exchange function. Therefore, price discovery as a function isn't yet happening. As we move to being able to activate financial markets around this thing that is already driving the market cap of the largest companies in the world, then we will have price discovery, and I predict that there will be a great deal of variation around different, the values of different data.
Did you want to react?
Yeah, no, I agree and tack on to what Heather and Navin had said, but I think that the market will decide what that value is in the end, depending on if you have that disease or not, and if it's highly desirable or not. But yes.
Thank you. Toby, last question.
Yeah, I'm intrigued by how far the panel thinks we are away from some sort of gigantic self-sovereign identity system by a healthcare system like the NHS, for instance. Since I've been in blockchain, I've been thinking this is going to happen 1 year away, but I'm becoming increasingly cynical that any government will adopt this. But I was intrigued.
1 year away from the year away where we are. Yes.
I don't see it coming from the NHS.
Yeah.
So I think if you're going to get self-sovereign identity, you're going to need appropriate stewards, you're going to need appropriate certification authorities. I think the government can help to provide that. I think you're much more likely to see it from someone like a bank first, because I think they see the challenge that they're facing from people like Facebook and Google, etc., who are now going to become the identity providers. So for them, it makes economic interest to enter that field, and they're not going to win by setting up their own ID service. Only very rarely. So places like Norway, I think, or Sweden have bank ID, which they use for everything, but the vast majority aren't going to have that, and the best way for them is to go for self-sovereign identity. And we're speaking to a few banks about that.
In the US context, do you feel that we're far away from that, or?
I really think this comes down to the public in the US. It's almost going to say, when will this revolution actually happen? And as things are coming out in the news and people are becoming more informed, it's how woke are people going to be about their data, and how long is that going to take? I guess, in a year it could happen, but how long does it take for people to actually understand it? Will it be that it takes more bad news to come out and to people be very informed very quickly, perhaps? But at least in the context of like what we're doing here, I think education is a good start, but how long does it take to educate? That's the question.
With respect to decentralized identity and self-sovereign identity, I think it's also important to recognize that we've got a tension between private and public sector interests. There are many early-stage companies offering something in market that if they were to be adopted in total, that you'd have antitrust problems. And if you have something coming from the government, and I say this generally to all governments, are among the untrusted entities by the population. There are the prevention of hegemony, both corporate and governmental, is a foundational principle that humanity through history will continue to strive for. So when we think about decentralized identity, concurring with my co-panelists, healthcare identity is only one context or one persona. We need to have compartmentalization of our various identities, and that is the only method that we will be able to use to prevent gross aggregation, cross-sectional aggregation of our data. And we have new technologies, leveraging blockchain and decentralized identity, but particularly leveraging advanced privacy preservation technologies to keep the different personas from being aggregated.
Thank you very much. I'm so sorry that we ate, 6 minutes into your break? But if you could please join me in thanking our fabulous panel. Thank you very much.